Welcome, everybody. We're just going to give it a minute for everybody to get in. We have about 33 people that registered, so I want to give people time for them to enter. So just give us just a minute. And if somebody out there, one of the participants, can try to just put a test in the chat. We just want to make sure that test Cheryl Kirby. Good. All right. Boom. We got it. Okay. So I think because we want to make sure we have time for everybody to hear this great webinar and have time to ask questions, we're going to go ahead and get started. So welcome everyone to the second quarterly CPNG webinar for 2023. My name is Cindy Snyder and I'm the Advanced Clinical Genomics Nurse Practitioner here at Georgia Core. I'm also the administrator for the Cancer Patient Navigators of Georgia. On the webinar with me today for technical support is Katrina Davis, and she's the program manager at Georgia Core. So just a few housekeeping notes. One is we're going to keep everybody muted during the webinar. If you're not muted for some reason, please mute yourself so that we can make sure everybody hears things clearly. The webinar has been approved by the Georgia Nurses Association for one contact hour, and at the end of the webinar you will see an evaluation. Once you complete the evaluation, you will receive the certificate of attendance. So please make sure, this is bold, underline, exclamation point, make sure you save a screenshot of the certificate or a PDF of the certificate, because we will not, I repeat, will not be emailing out certificates. And please post your questions in the chat. So, and at the end of the webinar, we're going to review the questions. So today we're very excited to have Dr. Margaret Quinn Rosenzweig presenting on navigation and palliative care and how oncology nurse navigators or oncology navigators can provide increased access to primary palliative care. Dr. Rosenzweig is a distinguished service professor of nursing at the University of Pittsburgh. Her CV is 40 pages long and represents a robust body of work, and you can view the entire CV online, which I just put the link in the chat. Dr. Rosenzweig's research focuses on factors that ensure all women with breast cancer receive timely diagnoses, treatment, and support. Dr. Rosenzweig's teaching focuses primarily on ethics and oncology care. She teaches strategies to improve patient healthcare provider communication skills, particularly in advanced illness and palliative care. So welcome, Dr. Rosenzweig. We really appreciate your time and giving us this really important information today.
Oh, it's really a pleasure to be here. Thank you, Cindy, and thank you for inviting me. I am at the University of Pittsburgh and have spent many years kind of thinking about ways to really ensure that patients with cancer receive, as was said, timely and equitable care. And so navigation has been a big part of that, and I want to just share that with you today. So I thought I'd organize this. I always like to do a lot of slides, but it isn't really, it's going to be as long as it looks. Advanced stage illness, thinking about advanced stage cancer, and really we can think about any advanced stage illness as kind of the new frontier. How primary palliative care has been kind of thought about in the context of this advanced stage illness, how patient navigation has been thought about. Three examples that I've been part of or have led myself, and what I kind of think about that now, and then the considerations that I think all of us in the business of patient navigation in oncology, and particularly working with advanced stage patients and patients at the end of life, need to think about because I do think this all works together, and this is definitely the way we need to go. But getting it there is going to be some of the considerations. So first, advanced stage cancer treatment. We know that when patients are diagnosed with a metastatic or stage 4 cancer, or, in hematologic malignancies, the advanced stage illness, that patients are told sort of, well, there's no cure, but that kind of is said quickly. And then they are, all the new therapies are discussed. And so we no longer say, check the palliative care box. That's all we're going to worry about. It's, well, we'll think about there's not a cure, but we do have drugs that can extend time. And once that is put on the table or into the treatment plan, then we are asking patients and their loved ones to really go on a very difficult, very expensive journey that requires a lot of them. And there's, at least in most of the patients that I see, not a real clear exit as to when it's time to say, no more treatment. I'm really going to focus on my wellness and focus on comfort care. So I think this is changing by the hour, and this is where we find ourselves and where patients find themselves. So we can't just say, well, we're worried about comfort only, because there is that promise of the extension of time with the remarkable new agents that seem to be coming every single day. The metrics for quality metastatic cancer care, according to the National Comprehensive Cancer Network, are that all patients have appropriate diagnostic staging, as their treatment is determined as per tumor, genomics, and their markers, whatever that would be for their individual tumors. You know that. The treatment is then as per tumor specifics in about 30 to 40% of the country. That is all determined by clinical pathways, where sort of the guarantee of guideline concordant treatment is there, because physicians, clinicians are expected to follow clinical pathways. Isn't true everywhere, but is increasing throughout the country. Patients are to be offered clinical trials when appropriate, and surveillance should be as in accordance with patient and family wishes. So that's in the NCCN guidelines. And then when it comes to care, there's a sort of vague integrated symptom and distress management, value-based treatment at each decision point, and each decision point usually means each progression, and then quality end of life care. And the quality end of life care are metrics that are a bit older, and those include limited use of the emergency department, acute care, and ICU in the last months of life, goals of care with each disease progression matching the NCCN guidelines, and no new chemotherapy in the last months of life, and no chemotherapy at all in the last days of life. And, for the patients that you see and follow, we know that these guidelines are not always followed, and that patients can have what is deemed to be poor quality end of life care, mostly because these discussions at each decision point don't happen. And so patients are left unprepared for end of life. So the study that changed everything was the Temmel study in 2010. And Jennifer Temmel at Harvard did a study with lung cancer patients in which the traditional palliative care model was kind of upended. And instead of just waiting until patients had progressed to the point of, well, does it look like there's a lot more treatment options, they integrated palliative care. And the findings from this study were so remarkable that it really changed all of the patient guidelines and changed everyone's thinking about how we're going to sort of do palliative care in cancer. So the study was modest, and it was advanced stage lung cancer patients. And so they just got standard care, or they had this palliative care provider. You have to really read in the sort of fine line, the fine print, that the provider was a nurse practitioner. That's not really put out there that out front, but the palliative care provider that saw the patients at each visit was a nurse practitioner. Now, Harvard is sort of a mecca of palliative care. And so, everybody who was involved in this is considered to be really a national expert. It was not a nurse practitioner, for instance, who had like a week of training and then went and did palliative care. They have very expert people doing this. Anyway, their outcomes were that patients had better quality of life. They chose hospice sort of more appropriately than intensive chemotherapy. And the really remarkable thing that got everybody's attention, not that patients felt better, but that the median survival time was prolonged. And that's where everybody started to say, wait, we should really be integrating palliative care. And truly guidelines were changed, it seemed like almost overnight. In a qualitative assessment of this study, they looked at, well, why? Why did patients sort of embrace palliative care earlier? And this is what was determined were the key ingredients of what was happening in that study. So the palliative care provider, again, mostly nurse practitioner, were building relationships, discussing cancer treatment and prognosis, but not focusing on end of life, talking about this is the treatment, this is where things are going now. And it was not a sign on the dotted line, the DNR, it was really kind of putting this in context. The preferences for receiving information, the early visits did not include any discussion of end of life. Everything was about symptom management, and family and friends were included. So the issue, although these findings were remarkable, was that this required a distinct palliative care provider. Again, Harvard, very well trained. This is a real place where they train palliative care providers. And there just aren't enough primary care. There aren't enough specific palliative care providers to meet the need. There weren't before the Temmel study, and there certainly weren't after all these guidelines started to say, well, we really need everybody to have integrated palliative care from the diagnosis of metastatic disease. It just can't happen. There weren't enough physicians, or there weren't certainly enough just trained people. So the guideline became that, well, wait, could we only use the palliative care providers when there are real intractable symptoms or really difficult cases? And for sort of the integrated palliative care along the way, could we use that every clinician who sees seriously ill patients learns basic palliative care, particularly focusing around communication, and then using the palliative care specialist as other specialists are used for more difficult cases. So primary palliative care was born, and it was billed as a low-cost intervention that used the existing patient resources, and but then had the potential to really change end-of-life cancer care. So all the time that this was being discussed in the literature, you always saw physician, even though, as I said, it was a nurse practitioner in that Temmel study, but it was always about this relationship between physicians and the patients. But then there was a question, well, could we do this for nurses? And that's where the CONNECT study started. So the CONNECT study was kind of born by Yale Schenker, who's a palliative care physician here, and here in Pittsburgh. And she thought, well, could we train infusion room nurses to provide primary palliative care and determine what the outcomes might be? I was a co-investigator on the study because I had a lot of experience in teaching nurses and nurse practitioners cancer care, and had been thinking a lot about particularly metastatic breast cancer where I worked, and knew Yale through that work. And so we sort of joined together, did a pilot study, and then she was funded to do the large study. So she couldn't randomize within one clinic because there would be contamination. So she used the extensive UPMC network in Western Pennsylvania and used 17 oncology clinics, randomizing the clinics to either a CONNECT site or not. And then you see here, there were, it's a nice study, 312 men, 360 women that were included in the study. The primary outcome was quality of life assessed by the FAAN. It was a pretty straightforward outcome. And there were lots of other outcomes that were measured. But the study essentially, and we'll talk about this in a minute, there was really no difference in the quality of life between the patients who were in a Connect site versus the patients who weren't. So what happened here? First, let's talk about the nurses. The nurses who were Connect nurses were selected by their managers at these are not the academic site nurses. These are community infusion room nurses who were selected to go to Pittsburgh to be trained for 2.5 days. The training was conducted by Yale, myself, and Bob Arnold, who's a palliative care physician here who does a lot around communication training. It was very, very structured, and we gave the nurses a really extensive manual. We started with sort of some simple tasks of introducing yourself to patients. We used standardized patients throughout the training. There was lots of time for fellowship and meals together and really sort of building a cohort of nurses. And by the third day, the nurses were expected to kind of do a complete visit using all the forms that they would use in the Connect study. And then the follow-up to that was that they were contacted weekly by the study staff to see how they were doing. And if metrics weren't being met, if they weren't doing their visits, or if in listening to some audio tapes, it didn't seem like they were following the protocol, then there was some mitigation in order to ensure that, that the study had strict quality measures. So the thinking around why the study might have been negative was that the primary palliative care delivery in the harried and busy infusion rooms, it might just not have been enough time to really give that dose of palliative care. There were some challenges in terms of making sure that everybody adhered to the 3-visit rule, because you can imagine all the logistics of a busy cancer clinic. But mostly it was thought to be this issue of dose intensity, that we were on the right path. It just wasn't that the nurses just didn't have the opportunity to deliver enough of the intervention in order to really change quality of life. But it wasn't all negative. The study that was recently published was that the patients who started without an end-of-life care plan, the patients in the Connect study were much more likely to, at the end of 3 months, have a signed end-of-life care plan designating a surrogate and at least kind of opening the literature around end-of-life care planning. So it was thought that, so the conclusion that was taken from that for the NCCN guidelines was that this is promising, and that perhaps nurses who are trained could be talking more about advanced care planning. Perhaps other components of the intervention may not be as practical, but at least a discussion around advanced care planning may increase the likelihood that patients would think about surrogate decision-making and think about end-of-life planning. So I was with Dr. Feldzinger. She was a DNP student who did a qualitative analysis of the Connect nurses to see what it was like for them to be Connect nurses. And she presented this at the Oncology Nursing Society Congress. And I have to say, she wasn't booed off the stage, but there was a lot of skepticism in the room about the ability to even do this at all. I have to say that Yale, when she presented this study to the administration at UPMC, they were very much in favor of it for multiple reasons. But it was difficult for her to continue to get the buy-in. As nurses, there was attrition with nurses called off. It was difficult for her to continue to get the Connect nurses the time that they need. Another student that I worked with, Jen Davidson, did a time study of infusion room RNs and just walked around with a time watch and just clock everything that they did and timed that out. And she found that most of the time, so you can see here the numbers of what infusion room nurses actually do. And they spend, not that much of their time in direct patient care, and certainly just a minuscule amount of time with anything that would be deemed to be palliative care. So this is a real sea change in thinking about this. The other thing in the qualitative study that Caitlin did was that the nurses felt very guilty about being Connect nurses. They were very proud that they had been selected, and they did feel like the training kind of changed them in their practice forever, that they learned excellent communication that they can always have, but that they felt that they were asking their colleagues to assume more work while they were doing sort of more touchy-feely things like palliative care, talking to people about how they were feeling and their symptoms. And, it says a lot about how we have sort of the true nursing trained out of us, and we are replaced with very task-oriented work. So it was a very interesting sort of debrief as to how the nurses felt. And then I started thinking about, okay, well, what will work? Could everybody in the treatment room be trained? And I mean, we know lots and lots of different nurses, and we know some who, just like the Connect nurses, would rise to the challenge, and others who would say no thanks, or others who may do it very, very badly. So I'm not sure that that's the correct approach. But everybody can be trained and held to some standards. I was thinking maybe this could be similar to patient acuity standards in an inpatient. If there are patients that required palliative care, then assignments could be altered. This is all said prior to COVID and the serious work shortage, so I don't know how much of this is possible at all. But then I thought, well, should we have a clinic-based attention to each patient proactively, and how does that work with navigation? So I started thinking about oncology nurse navigation, and the Oncology Nursing Society has done a lot of work in this area. They do have a care model where across the cancer trajectory as to all the different components of what oncology nurse navigation might look like. So in consideration of the Temmel paper, of Yale's study, the Connect study, and then this thinking about, the rising influence of navigation in cancer care, I started to think about how can we do this better for our patients. Now, I work in the world of acute breast cancer, and so our palliative care is focused on metastatic breast cancer. And I could do a whole talk on this, but there are a lot of issues around metastatic breast cancer that they feel very ignored. That it's all based on this. We're winning the fight in the pink. They're like elephants in a pink room, is the way they describe themselves. I work a lot in equity in cancer treatment, and we know that there is disproportionate suffering among Black and poor women. So these are all studies that we've done along the way, but we know that Black women suffer the cumulative health effects of racism, poverty, and neighborhood deprivation. I'm not sure if Pittsburgh is uniquely terrible in terms of neighborhood deprivation, in that it's voted the second worst place for Black women in the United States in terms of economic opportunity. And so it is a difficult place to be sick. And we've documented this in numerous different ways, including for symptom incidence and financial toxicity. So with the help of a local Komen organization, I got a grant to do a combination of clinic-based oncology nurse navigation. And I was able to hire a retired nurse who wasn't quite ready to retire, but very ready to get out of the day-to-day. And she did our weekly review. It took her about maybe 6 hours per week. And she got the list of the patients that were coming in for the next week. She looked them up and started an Excel spreadsheet. So that sounds like a tremendous amount of work, but as you know, the patients they repeat. So once you sort of get them into the spreadsheet, it's kind of just an updating. And then she did she looked them all up, which was the most time consuming part of that. And then was able to lead the meeting because she knew date of the metastatic breast cancer, the sites, and what was up for that visit. You know, patients come back very commonly every month, every 3 weeks. And so we were talking about them a lot. And we didn't spend time if there wasn't a whole lot to say, but we then put the list in front of the collaborative RNs who are responsible for those patients in the visits and said, like, is there anything that we should, you know, talk about? And at the meeting, I'll just go ahead here. Oh, sorry. We have palliative care, the study folks, we have dietary, we have the nurse navigators. They're not nurse, they're social work navigators. A few of the collab nurses who were able to come, and then a linkage to some of the behavioral studies. Their coordinators are welcome to attend. So we have any of them on any given week. And then afterwards, a meeting update is sent to the APPs who are in clinic at the time of the meeting and they're not able to attend. So we do update them as to what, you know, what is being done, mostly the referrals that are being made. So another student did a 3-month pre and post outcome of this for her DNP project. And we did find that patients had more referrals. So we did just usual care for the 3 months before, let the program get sort of embedded for a couple months, and then we did a 3-month post. And we saw more referrals, we saw better, we have an iPad where patients report their symptoms and overall well-being at each visit, so we were able to record those, and did see a significant improvement in overall symptoms and overall well-being. And the only thing that we didn't see improved was clinical trial enrollment. It just didn't budge. So after we had this, and it was really successful, we were all very proud of it, the funding ran out. And I went to administration at the hospital and said, look, we have these great outcomes. We also decreased emergency room visits, and we were able to decrease the number of calls to the clinic, which, as you know, is very time consuming. And they were not willing to fund it. We also saw that we could do this for $750 a month. I mean, really, it was not an expensive proposition to you know, really improve symptoms, quality of life, and to sort of save people, you know, admissions and ED visits. So they gave me a list of other grants that I could write to keep it going. You know, it was really, really disappointing. But the clinical staff really wanted it to continue. And so the nurse manager was willing to make it part of a position or a clinical ladder project. And that's how it has evolved. It's a clinical ladder project for 2 of the RNs so that they spend some hours per week doing this. And then that they can be promoted based on that work. And right now, we have about 30 to 40 minute meeting. The days change. It is once a week, but we have changed the days several times actually recently because of schedules. But it's usually about 7:30 in the morning, and the nurses would like it to be at 7, but everybody else isn't there, so we have to kind of compromise on that. And then I take the responsibility for sending the weekly summary to the APPs. So it has remained, and we're very proud of this. So it is somewhat nurse navigation, but there's not a specific nurse involved, but clearly a nurse-run program that I think the physicians are aware that this exists, but really are not involved in it. Now, from that, we still saw that Black and poor women were not, we're still having a lot of difficulty at the end of life. And so I was able to get funded to do a program called the Doula AC, which was really the principle of a doula, but for advanced cancer and then the end of life. And we trained community health workers to be the doula, and they mostly the patients found that they liked the doulas to come with them to clinic, and to kind of sit with them the long hours of the clinic, as well as help them be advocates. And we are just finishing up this study. We were able to do 10 patients in the pilot study, but have you know, really qualitatively, at least, we haven't done all the analysis yet, really strong results in terms of what a benefit this was. Now, I took on the responsibility for training the community health workers to do the doula rule and providing support along the way. I think this would have to be a nurse to do this training and to provide that support. Because there were many, many issues that came up where sort of a clinical just opinion was needed. These are non-medical people, but they did need some help sometimes navigating. I think the challenges for navigation in primary palliative care is to define the role. And all the papers that have been written kind of talk about two very distinct roles, sometimes combined, sometimes not. One is instrumental, and that's the task-oriented sort of logistics. Let's get you a transportation voucher. I think that's where a lot of people think about patient navigation. Let's just help you get from A to B. And but the relationship that grows really helps the patient sort of navigate the clinic better. And I think teaching patients through this sort of supportive relationship how to navigate an often adversarial to them situation can be very, very helpful. We do need to have training to ensure competencies are met. This idea of supervision and training of the staff, I did find that to be extremely time consuming in the doula study. So it was something I sort of took on, but that would need to be distinctly different role of an RN being the supervisor. And then we have to demonstrate the cost effectiveness of this care. So this has been demonstrated over and over and over again. There's lots of papers that are written that say, yes, having these navigators in different forms can really improve not only patient outcomes, but the cost of care. But when you start talking about palliative care and end-of-life care, the metrics may need to be different. And what I wish I would have done in terms of the study that we did, where the administration didn't, even after we showed great outcomes, didn't support any further funding, was I wish I would have gone to them first and said, what metrics will speak to you? What do I need to prove to you in order that you would continue this if I show those metrics? Oncology Nurse Navigator does have, the Oncology Nursing Society does have Nurse Navigator core competencies that are published. It's a really, good document that does cover all the aspects of what a navigator may do, but this is for a nurse navigator. I think we could look at this, or I looked at this for training the community health workers, just to make sure they had a taste of all of these competencies. But we have to be clear, I guess I'm preaching to the choir, that the nurse competencies and a community health worker competencies are not intermixed, because we don't want to give away, the nursing role. I have a proposal in now to the NCI that'll be decided this month about training community health workers, again, through nurses serving as the trainer and liaison, to embed them on clinical trial teams. Because as I said, our previous work had not budged clinical trial enrollment. And so I was thinking about having community health workers on the teams, meeting patients over and over, developing that relationship before even a clinical trial is offered, so that the patient, when a clinical trial is available, would feel more comfortable and more supported in a decision to enroll in a clinical trial. So that proposal is out there. And then again, I think we have to consider the new outcomes, the new metrics of what people would be looking for in terms of cost savings for palliative care, and start with the end in mind. So I think it's there. I think all the need is there. The pieces are there. I think the literature has demonstrated that this is necessary, cost effective, excellent for patients. There's no reason that this wouldn't then just work across the board in palliative care. But we do have to document what we do, speak loudly, and let the world know these outcomes in order for this role to continue to develop. So thank you for letting me speak. This is just a few of the many people that I work with, and happy to further the discussion. I'll stop sharing.
So, okay, so I think what we're gonna do is we are gonna try, hopefully, and allow people to unmute themselves, because it may be that maybe people don't have a question, but they have a comment about their environment that they're working in with palliative care
Sure.
or metastatic breast cancer or social work, oncology social workers, because I know they're out there in the participants because I saw your name. Uh, so while Katrina, let me know, Katrina, if you're able to allow people to unmute. You may have to do it individually on every participant. But I did
If
put,
you would like to unmute, if you can raise your hand, then I will allow you to talk and unmute.
so
Okay, we
yes,
have one, Cheryl Kirby.
great.
Good afternoon. Can you hear me okay?
I can, yeah.
Okay, great. Well, thank you so much for your presentation. I love seeing the doula piece that you brought in. I think that that's something that people don't really think about as far as the work in which we do. I'm an oncology social worker in Atlanta, and we used to have more of an outpatient palliative care team meeting, which I love their approach about bringing. We had a multidisciplinary approach. We had our chaplain, social workers, a dietitian, and we, as you mentioned, we had several nurse practitioners leading that team meeting. So it was not always an MD. And their approach in working with the patients, I felt like that was very well received with our team and with the patients. Unfortunately, with COVID and like you mentioned, kind of the need within the inpatient setting has kind of been put on the back burner, but I'm hoping that they'll circle back with it. But I love seeing that the fact that your referrals to social workers increased a big chunk after having that. And so we're always trying to let the nursing staff and the direct, clinical staff know about our role and how we can help support and advocate and help with that quality of life with our patients.
Thank you. During COVID, we went to Microsoft Teams and it did feel like, oh, are we just, this is really sad. But, we, as soon as we were allowed, we were back and we all came back in person. So, just to get that spirit and, of course, like any meeting, there's a few minutes before and a few minutes after where you kind of bond a little. And I think that's really important in that work. So, we, you have to keep it going. You just, it's hard sometimes. You feel like you're pushing a rock up a hill. But,
yes,
absolutely. I was surprised at how much the nurses did value it. When it looked like I said, I just don't know how I'm going to continue this. And I probably would have just done it myself, but it is a lot of work to sort of get that meeting together. It's a few hours of work.
Sure.
The other thing is the nurses who the nurses who see, who manage all these patients, they said it's good to get those names in front of them once a week, because sometimes they said they just truly like forget about people, if they haven't heard from them or, they just, whoa, whatever happened to her. I know that as a patient, that would not be comforting, but I can see, in these busy clinics.
Yes, it's whatever, you got to put that fire out first. And
I see in the chat a question about the online. There's a wonderful training that I took, and actually a friend of mine who's a chaplain, I was raving to her about this training, and she took it as well. It is called ANELDA. It's the International End of Life Doula Association, INELDA. They have online trainings that start, every few months. And it's a commitment. It's several hours. And they do ask you, to think about your own end of life, to engage with other people. I did it virtually. To engage with just a partner that you meet randomly about what your end of life would look like. I mean, you have to be pretty vulnerable, but it is, I am kind of, after all these years, I like, more training, but it was truly wonderful. The way that they integrated like a little bit of didactic, but then it was very experiential. And, you know, I can't recommend it more highly. And a lot of people in the group were oncology nurses or oncology social workers.
I put a link in the chat for the article that was published, the title, "The Primary Palliative Care Improves Uptake of Advanced Care Planning Among Patients with Advanced Cancers," which Margaret was one of the authors on. But I mean, I just thought I read the article and I was like, wow, it's in the Journal of the National Comprehensive Cancer Network. I thought maybe Margaret will give us a webinar because I just was so impressed with this article, increasing the uptake of that advanced care planning, because I think that's just so important for people, even without advanced cancer, but just, you know, the fact that they could train nurses and let them sort of help people work through that process.
My only worry about this is that the take-home message would be, oh, we'll make the nurses get the advanced care planning. Like, I don't think the nurses want to do, you know, just with, you know, and how institutions are. Well, this paper said that nurses can do that, and they missed the part of the 2.5-day training. And, you know, that's my worry, that we may have created an expectation that now infusion room nurses are supposed to get advanced care plans done, without that. People will just overlook all of the training, the communication training that went into that. And it really would not be possible to train every infusion room nurse in that way. Perhaps a few infusion room nurses from each infusion room, if there's, you know, enough, could say, I would do this, but you know, I'm just not sure how all that would work in those, you know, how busy infusion rooms get.
Do you have the link or information about doula training? You could email me and I can.
Yeah, I
include it.
certainly can. Sure.
Yeah, I'll put it in the June CPNG newsletter that'll be coming out first week of June, and I'll put that under one of the resources. So if you email me,
Okay, I can send it too as soon as we're over. I can.
That'd be great. That'd be great.
Yeah, they actually have also were co-investigators on the doula study, and have helped a lot in sort of thinking through, you know, how, because our study wasn't necessarily for the very end of life, and the doula training is more for sort of sitting the vigil, not necessarily, but more towards the very end of life. And we are in that wide world of advanced cancer, and, you know, the years in metastatic breast cancer, literally the years of treatment that people get.
Right. Anybody else have a question or even a comment or want to add to the conversation? Joel, I see your name out there in Athens. Hello, Joel. But yeah, anybody. Okay, who has that? There's Joel.
Good afternoon.
What's up, Joel?
So good to see you, and thank you for this presentation. I am here just continuing to go deeper and broaden as a manager of oncology social workers in the Piedmont healthcare system in Atlanta. So yeah, this is all very helpful. And I think, you know, one aspect of what you bring up is the fact that I think our integrative approach to patient care has got to be across the board, across disciplines. I think both within and across that, an understanding that there is overlap with nurse navigation, social work navigation, physician, and, you know, advanced practitioners care. We've got to know what each other's doing and be able to cross those lines.
Right. Yeah, I appreciate that. I think one of the little issues that I had to work out with the doula program was that some of the oncology, the social workers in our clinic, for instance, somebody needed a new phone, and she had asked the social worker, but had also asked the doula. And so we were helping her get a new phone, and I should have just gone right to the social worker, because the social worker was like, wait a minute, who's doing this? And was a little annoyed. So I learned, for the practical issues, that there are ways that patients can get sort of this practical help. And so to jump in kind of doing that was not helpful. And that was a very valuable lesson learned. So I think for the more practical logistical things, there are not lots, but there are ways that the social workers help patients. And I think I really needed to focus more on the relational aspects. So but yeah, it's not necessarily stay in your lane, it's really appreciate where everybody is on the road. So
We did, thank you, Joel. We did have a question. What could we do today to help our cancer patients with resources and peer-to-peer support?
I don't know if it's unrealistic to think two things. One is that the nurses where you work could really use training. They are very hungry for this. And whether or not, you can't really turn them into connect nurses, but I think if in your positions, you could do something around communication, around just some common end of life issues. I think one of the things we did in the Connect study was try to help with symptom management, and I don't think the nurses were particularly comfortable with that. They had their own way of getting patients help, and they weren't advanced practice providers, so I felt like that was hard for them. But I think in terms of just talking about end of life or in advanced directives, however your institution does that, I think it shows the nurses that people are thinking about them, and it can, really, as in the Connect studies show, that is an outcome that can happen, that just talking to people without asking them to sign anything, just asking them to think, if you became seriously ill, who would speak for you? I think that's something that could really be just very singularly helpful. And then if you're able, I don't know if there's any philanthropy money or to just get a little bit of money to try to think about a weekly meeting where you do sort of run the list of patients, either inpatients or outpatients, just thinking about giving everybody like the honor of a few seconds of everybody's brain power to think, what could we do for this person? The patients don't know that we have these meetings. And I think they would be happy to know that, everybody thinks about this one person for at least a minute out of the week.
Thank you. Amy Hoke would like to ask a question. You can unmute, Amy.
Good. Thank you so much for the presentation. I thought it was excellent. I'm in a little bit different situation, and Cindy's well aware of that. I have worked with a surgical oncologist for 25 years and did training at the Harold Freeman Institute, and I'm a patient navigator. So I'm not a nurse, but I'm in the room when he tells them that they have cancer, and then I walk the journey with them. So a lot of the training that I find, this is where I run into barriers, is my background was as a medical technologist, and then I went into management, and I've just kind of walked a different road. So a lot of the training is, of course, for nurses and not for patient navigators necessarily. Right. And I run into a lot of barriers with that when I want to do extra training. But it's so great to hear this, because for the last 15 years or whatever, I have, done this already, where I'm just trying to be supportive. They have my cell phone number. I get calls on the weekend. I just had dinner with one of them because she unexpectedly lost her husband right in the middle of her chemo. And so she said she was lonely at 5 o'clock. And I said, then let's go have dinner. And so I try hard to be supportive and give them what they need without crossing that line. you have to stay in your lane, like you said, and know what your limits are. But having the doctor kind of right beside me helps me also with, if they have medical questions that I can't answer that. But as far as, nausea, those kind of things, I can give them the support and help them with that. So it's just, I really thought your presentation was great. And I just need to figure out how sometimes I can get some more of the training that I would like to get, but without that nursing degree at the end of my.
Right, yeah. I'm on a panel in Pennsylvania for just cancer equity. And that's one of the things that we've been discussing, that there's a broad category of non-nurses that are called community health workers. But I mean, the scope of that, like you have so much experience, and you would not be in a general training of a community health worker who's kind of just hired and told certain things to do, but unfortunately the non-RNs kind of get lumped together. So I feel your pain. The ANELDA course, it doesn't sound like you're so much at the end of life, but more during treatment trajectory.
For me?
Yeah.
Well, I mean, we follow our patients
Regardless.
all the way through. The doctor
Okay.
does. So I have been there at the time of diagnosis, and I've sat on their bed in hospice and held their hand and sang hymns with them, if that's what they want, until the end. So, and then attend services. So I kind of do it from the beginning to the end.
Okay, yeah. So you may find the ANELDA training to be really, really helpful, because it is for, as I said, there's nurses in that training, but it is really non-medical in focus. It's really,
Yeah, I'm really excited about that.
yeah. And then people start their own practice. They do this. There's end of life doulas in Pittsburgh that you hire, and they'll come and for the last months of life kind of be there, sit the vigil, and help the family. In addition to, if there's a hospice involved or not, the nurses can't be there all the time. So it's interesting.
Thanks, Amy.
Crazy, right?
And then we had one other comment from Cheryl, which just sort of reiterates what we've been talking about. With more training, this may help the practitioner / provider feel more comfortable with a sometimes uncomfortable subject. And
Right.
I have noticed that myself. It's just like, woo, that is a tough one to get them to start that conversation sometimes.
Yeah, I think that's why the embedded nurse practitioner in Tamel's study worked so well, because it wasn't just end of life. It was this person that just was there and kind of walked that journey with them. So it didn't have to be this all of a sudden awkward conversation. But
right. Anybody else would like to make a comment or ask a question? We have a couple minutes left. I just want to remind everybody while you're thinking about it. This webinar has been approved for one contact hour through the Georgia Nurses Association. So once I end the webinar for everybody, an evaluation will be there for you to complete. And when you complete the evaluation, you'll see your certificate of attendance at the end. So just make sure you save a screenshot or, copy and paste to a Word document or something. So you have
here's the website for ANELDA.
Oh, there you go. I'm still going to put it in the
website. You can sign right up.
Yeah, I'm still going to put it in the June newsletter.
Okay.
People didn't attend today, because that's a good resource to have.
And their training can be a little pricey, but they also will do scholarships. And
Okay. Again, Margaret, I really appreciate your time today. Going.
oh, I appreciate you asking me. Thank you. As you can tell, I like to talk about this.
Well, when you were saying that you could talk about metastatic breast cancer and a whole nother webinar, I might reach out to you again for that. If that's something you really like to talk about, we always can use a webinar. So that's
yeah, that's a whole interesting world of you can do any treatment, but also there is a real advocacy piece to that as well.
That's great. If we don't have any other questions, then I can give everybody back 2 minutes of their day or a minute and a half. And I appreciate everybody attending today. This webinar, you're welcome. This webinar has been recorded and it'll be up on our website, Georgia Corps' events page, for everybody to view again. And the certificate, actually, if you do view it, like you'll get the certificate after this live, but if somebody views it, I can always eventually send them a certificate. It's just for today, I won't be sending out certificates because you'll get it. But anyways.
Well, my grandbabies are in Georgia, so I get there a lot.
All right, mine are
right.
here too. Okay, well, everybody have a good rest of your day.
Take
Thank
care.
you again,
Thank you.
Margaret. Okay, thanks for attending.